Hello, everyone. As many of you already know, my name is Nuna Smikla. I'm truly honored to be here with you today. I am a certified neonatal PICC nurse and have had the privilege of serving as a vascular access team leader, specializing in PICC and arterial line placement in the NICU for over 20 years. Today's session is a 4-hour hands-on workshop focused on PICC line placement and management. Our goal is to equip clinicians with the knowledge and skills necessary to confidently manage extended dwell peripheral catheters, specifically within our neonatal and pediatric units. Throughout this class, we'll cover a range of essential topics, including indications for PICC use, benefits, and current evidence-based practices. We'll also dive into the ongoing maintenance of these lines, such as dressing changes, line adjustments, removal techniques, and the identification and management of potential complications. Thank you for being here and for your commitment to safe, high-quality vascular access care. Let's get started. Workshop Overview. We'll begin by exploring the current guidelines and standards related to neonatal vascular access. The goal is to enhance your clinical decision-making and patient outcomes through informed catheter selection and placement strategies. After completion of this workshop, you will be able to describe the difference between PICC line and midline locations and therapy, appropriate for administration, including catheters, care, and maintenance. Quality management related to infusion therapy seeks to ensure that desired outcomes are achieved. The most fundamental of these desired outcomes may include, but are not limited to, successful completion of infusion therapy. We want to elimination of catheter-related complications, minimizing the number of venipunctures per patient, reduced supply and labor-related costs, increase parent-patient satisfaction and healthcare worker safety. The first step in successfully achieving these outcomes is to identify and understand the process. A process can best be defined as a series of interrelated steps that closely impact the outcome. The critical factor is that these steps are all interrelated. If a step is missed or altered in any way, the outcomes will not be predictable. So, our course schedule of 4 hours today will include discussion of the concept of extended dwell peripheral venous access, clinical indications and contraindications in the neonate, and indications for catheter tip locations, issues surrounding osmolarity, pH, and chemical properties of IV solutions and medications, along with hemodilution and blood flow associated with venous devices will also be addressed. Then, followed by 15 minutes for questions and answers. After that, we'll discuss clinical consideration, policy related to PICC line, including site preparation. Next, we'll have 15 minutes break. We will resume with the discussion of venous anatomy, review of the histology of the vein, discussion of veins suitable for use in the neonate and infant, measurement techniques to correctly determine desired catheter length, and tips to facilitate successful placement are included. Includes problem-solving tips and techniques to prevent and/or manage complications, post-insertion considerations, catheter care, and maintenance. Assessment of a patient with an extended dwell peripheral catheter will be reviewed. Discuss ongoing nursing management issues along with identification and management strategies for potential post-insertion complications. Site maintenance, radiographic confirmation, documentation, insertion, and related complication. The last half hour, we will practice hands-on changing and removing PICC line with open discussion. That will be the end of the class. Extended dwell peripherally, inserted catheters have really advanced how we care for neonates and infants. Made from long-term materials and inserted under sterile technique, they help minimize therapy interruptions, protect fragile veins, and lower the risk of infiltration, extravasation, and complications tied to central lines. Traditionally, Peripheral IVs were the go-to after umbilical catheter removal, and many facilities still use them to avoid more invasive lines. Now, with a variety of catheter types, differing in size, length, and material, we can better match each patient's needs. When the catheter tip ends in the superior or inferior vena cava, it's called a PICC. But even if the tip stays in a large peripheral vein, it can still safely deliver therapy. Midline catheters, placed in areas like the antecubital, scalp, or saphenous veins, offer another flexible option, especially useful based on the infant's condition and vascular access requirements. To choose the best vascular device for the infant, it is important to anticipate the length, need for, and type of fluid and medication that will be needed throughout the illness. PICC nurses are responsible to make the decision about vascular access device selection to reduce of infusion-related injuries, especially in extreme preemies. Bedside nurses are responsible for ensuring safe administration of all medications and solutions. If an infusate has been deemed to cause vascular damage during administration, it should be given in the largest vein possible to allow adequate hemodilution and blood flow to decrease this risk. With repeated administration of certain agents, central venous access may be needed. Thus, the factors to consider when selecting the appropriate catheter tip location, i.e., peripheral, midline, or central venous, are discussed within this section. There are four primary issues that need to be considered in selecting the best vascular access device for the patient, including osmolality pH level vesicant or irritant properties, blood flow patterns. Isotonic solutions are those having an osmolarity of 240 to 340 milliosmoles per liter. Hypotonic solutions have an osmolarity less than 240 milliosmoles per kilogram, and hypertonic solutions have an osmolarity greater than 340 milliosmoles per kilogram. The osmolarity of IV solutions and medications given to infants are listed below. Medications have varying osmolarities based on chemical compounding and delivery vehicles. As the table demonstrates, the final osmolarity can frequently be altered towards an isotonic solution based on diluent. Collaboration with pharmacies can often lower the risk of chemical phlebitis. If the final osmolarity cannot be altered, the medication should be given slowly to allow for increased hemodilution. If repeated administration is necessary or the osmolarity remains greater than 600 milliosmoles per liter, central venous access is recommended. Please see Table 1 from hands out. The pH ranges of a particular medication can vary because of compounding differences. When giving a medication having a pH outside the normal range, which is 7.35 to 7.45, the blood helps to buffer the pH of the medication towards normal. So, if acidic or alkaline medications need to be routinely given, consider administering them into the vena cave to enhance blood flow and hemodilution to minimize potential damage to the peripheral vasculature. Due to their potential for tissue damage, peripheral veins may not offer sufficient hemodilution to safely administer these medications. Now, can anyone tell me of any medications in the NICU that have pH range of acidic and alkalotic, which needed to be given via a PICC line because it can irritate to veins? Yes, vancomycin pH of 2.5 to 4.5, irritating to veins. Vesicant potential acyclovir pH, tilde 11 alkalotic when reconstituted, which can crystallize in renal tubules, usually given via a PICC line. Ampicillin pH, approximately 8 to 9. Calcium gluconate pH, approximately 6.0 to 6.5 may still cause tissue damage if extravasated, while dopamine pH, approximately 2.5 to 5.0 risk of tissue necrosis with infiltration. Epinephrine pH, approximately 2.2 to 5.0, cause vasoconstrictor, thus, central line is preferred. Phenytoin approximately 12. It is highly irritating. Risk of extravasation, dwell time, and infusate limitations. Current literature shows that dwell time in neonates can be up to 4 times longer than short PIVs. Mean dwell times range from 6 to 10 days, with a median of 7 days. The INS recommendation has no specific dwell time limitations. Radiographic verification is required to confirm catheter tip location. Infusate limitations. Osmolality less than 600 milliosmoles per liter. pH between 5.0 and 9.0. Indication: therapy lasting more than 6 days. Medications must not have irritant or vesicant properties, and their pH should be less than 5 or greater than 9. Osmolarity should be less than 600 milliosmoles per liter. Patterns of blood flow. There are two types of blood flow in the veins. Turbulent flow occurs when blood moves in irregular, chaotic patterns, often causing increased resistance and potential damage to the vessel walls. Laminar flow, characterized by smooth, parallel layers of blood flow, providing efficient and less disruptive movement through the veins. Examples of veins with good laminar blood flow include superior vena cava, inferior vena cava, basilic vein, subclavian vein, popliteal vein. Section 3. Clinician considerations will contain the discussion on establishing an EDC, extended dwell catheters, program within your facility, qualification and certification professional practice resources, clinician responsibilities, caregiver qualification facility, responsibilities, policies, and procedures. These guidelines are designed to help you establish an EDC program in your facility. You don't need to be proficient in EDC placement to get started. What matters is having solid education, hands-on proctoring, and ongoing support during rollout. Key steps include setting clear policies, choosing your EDC insertion team, selecting the right products, and training staff on procedures and protocols. You'll also want a system to monitor outcomes and drive improvements.